My name's Rob Galloway. I'm an honorary clinical professor at Brighton Sussex Medical School. I'm an A&E consultant down in Brighton, and I've been involved in patient safety since I've been a registrar all the way through my consultant career. I probably went through the same journey that most doctors do. I'd done loads of exams. I was a senior registrar, about to become a consultant. I thought I knew everything, and I was probably far too arrogant for my own good and far too arrogant for my patients' good, in all honesty. I had a case which totally changed me. And I was an IT registrar, and it was actually during the swine flu pandemic, which was similar to the COVID pandemic, but didn't happen in terms of we planned for it. Everyone was panicking about it, but for some unknown reason, the numbers just weren't what we expected. We had a patient who I knew a little bit. He got admitted for a query swine flu, and so we were all in PPE, and so it's pretty similar to how it was during COVID. And I did the ward round, and I saw him, and it turned out to be a bronchopneumonia. Said, we need to put you to sleep and take over your breathing, because at the time we only had on high pressure forced oxygen, what we call CPAP, but we need to intubate him. I said, we're going to do it now. We can wait a couple hours, 3 hours, but if we don't do it by the end of the night, you would die from respiratory failure. But by intubating you, we can save you. And they all agreed that was the right course of action. And I was about to set up for the intubation, and I got a call from A&E to go down to see someone completely different. I called up the senior anaesthetist on to come and see them. And the senior anaesthetist went to review, completely agreed with my plan, and he put him to sleep, and went to prepare to intubate. And at the time, this was 12, 13, 14 years ago, we didn't have checklists. We didn't prepare for what if something went wrong. We didn't discuss, verbalize how we'd cope if what we expected didn't happen. But why would she? Because he was a very, very easy to intubate gentleman. He was young, he was healthy, there was no medical problems apart from the pneumonia, and he had no difficult airway issues. But when they went to intubate, she thought she intubated, but there was no carbon dioxide monitor to tell. It was only when the saturation started falling down from 98, 96, 94, 92 that they realized they hadn't put the tube into the trachea and got it in the esophagus. So she came out and did what you meant to do, which is bag valve ventilation, and it was called an eye gel. It was called an LMA then, but it was an eye gel which you basically put into the back of the throat and ventilate. But when she did that, she couldn't ventilate. And at this point, you're meant to go down this can't intubate, can't ventilate, difficult airway scenario, which actually she'd had a Viva the month before on and had done amazingly. She was a brilliant anaesthetist, about to have a consultant job, never had a complication. But she lost situational awareness. And whereas she was trained and knew what to do, and other people in the room knew what to do, she carried on trying to intubate. By the time they actually got the tube in, his saturation has been about 50%, and they've been like that for a long, long time. And he was intubated eventually, but what should have happened was a hole in the neck about 20 minutes previously. He got better from his pneumonia, but he was discharged to a neuro rehab ward and not a normal ward, and he died 3 weeks later from hypoxic brain injury. And we got a letter from the family which said, thank you for getting an extra few weeks of life to our loved one. And it struck a chord with me. It really struck a chord that the family were thanking us, but actually this patient died who shouldn't have died. And he didn't die because of a lack of knowledge. He died because of a lack of human factors, a lack of teamwork, and but mainly a cultural issue. Because this doctor was brilliant. The unit was brilliant. The consultancy supervisors were great, but it was the culture of having checklists, working as a team, discuss what would happen. He was our primary victim, and there was also a secondary victim. The anaesthetist knew that things could have been done differently. They knew that if you'd had a checklist for the CO2 monitor, you'd have realised straight away that there was a problem. If you discussed with the nurses what to do, and there was a flat hierarchy, they'd have been able to say, hang on, don't we need to do a trachea? But she knew things could have been done differently, but also knew that there was no culture to change. 6 years at medical school, 12 years training, she never worked or saw a patient ever again. She was the secondary victim. And it was at that point it made me realize that I didn't know what I thought I knew. I wasn't good when I thought I was, because I would have made exactly the same mistake as her. I'd done exactly the same. There's no way I'd have used a checklist. I wouldn't have had a CO2 monitor. I wouldn't have discussed with everything, anybody. I'd have blithely gone ahead and intubated because I'd not really had many complications, and exactly the same thing would happen to me. And it made me realize that actually the culture of medicine has to change. And so I've spent the last 12 years trying to change things. I've set up a load of prompt cards, human factors courses. I do a load of courses throughout through various organizations, and one-day courses, really trying to look at a different way of doing things, from the traditional human factors of team working, decision making, through to cognitive biases, but also the culture and how we look after ourselves to make sure we don't make mistakes. So I've set up these one-day courses because I'm so passionate about them. We've had about 5,000 people through the courses, and I'm writing a textbook on it. I've really been pushing it, and it's making a difference. I originally brought in checklists to our A&E department for all the high risk areas like intubation and sedation and central lines, and people just wouldn't engage. And I realized that it's because it was cumbersome and tiresome. And so I went back to where I originally got inspired by checklists, the Wetherspoons pub. But what they do is they just have a laminated card where you just follow, 1, 2, 3, 4, 5, 6. They don't, when they make a cocktail, for example, they don't tick a box and then put it in a file that they followed the prompt card. When pilots follow a prompt card, they don't tick boxes and put it in a file they've done it. It's just recorded by the back box. And so I realized that I was auditing the wrong thing, for example, as well. Was the checklist ticked properly? And some of them I was at it, and it was a brilliant sedation or a brilliant intubation, but it wasn't ticked in the boxes correctly. And I was saying that's an incorrect sedation, which is crazy. And other occasions where the sedation was done perfectly by the tick box, but actually they were ticking it without even looking at what they're doing. And so ticking a box and checklists weren't making the difference. And so I've got rid of them all and changed it to prompt cards, which were based on the Wetherspoons pub, where maximum of 6 points. And you just literally, it's laminated, you read it out and make sure someone else is responding. I think there's two main areas. One is about trying to change the culture, but actually we're trying to change a culture in an incredibly stressed NHS, and where there's massive problems with staffing. And I manage a lot of junior doctors. I manage 500 junior doctors in my medicine A&E division. And if there's rota gaps, that's going to make it so much harder to create a safer environment. And so one of the big things I've been doing is on workforce. And I've created systems where people self-roster and are annualized rotas, where where people want to come for the jobs. So, for example, I've got 74 clinical fellows who do 25% of their time teaching or 25% research, and the rest of the time doing clinical work, but they self-roster when they're working. So it's not like the old, the traditional things if they just get a template, and if they're getting married, they've got to swap their own shifts and they're told they can't get married, which puts a load of doctors off. So I've created these systems, and it's working brilliantly in Brighton. And just a random plug, if anybody is interested in jobs, please email me, robert.galloway@nhs.net. Sorry to get a random awful plug in. We've got lots of F3 and also registrar jobs, but we are now locum free completely across every single medical ward and 2 A&E departments. You don't traditionally think of that as patient safety, but actually you can't create a safe systems unless you've got the staff to do it. However great your prompt cards are, if you've got no one to do the prompt cards, it won't work. And it's transformed our ability to care. And so, for example, we've had a 68% reduction in medical emergency team arrest calls at the weekends because of increasing our weekend cover. My current environment, in all honesty, is incredibly challenging. I've got 20, 25 people in a corridor on a large number of shifts. I have patients waiting 24 hours to get out of a corridor into a cubicle. I have patients waiting 3 days for a bed. This is not my hospital. This is A&E departments up and down the country. The issue is, how do we produce safe environments in that environment? And that is incredibly hard. And you've also got people who are so upset about what's going on, they don't realize that there are ways of making those difficult environments slightly safer. In terms of the future of patient safety, we've got a lot of the systems, like we understand how to make decisions in terms of cognitive biases and things like pretest probabilities and interpreting results. But what we're not doing is integrating with the technology. So, for example, if I'm doing a prompt card, I should have the patient information system. I should just click that I'm about to do a sedation, and the prompt card will come up on the screen. If I'm making a diagnosis, I want computer-aided diagnosis. For example, if I see somebody with a pretest probability, for example, of a lung clot, and I'm doing the D-dimer test, I want to know if the D-dimer test is positive or negative, what the post-test probability is. That data is out there. We all understand you go from pre-test probability to post-test probability, and each test has a sensitivity and a specificity. But what we're not very good is using computers to help us make our diagnosis, because that's not de-skilling medics. That's not taking away our specialism. That's helping us become better doctors. Mood. Everybody's mood. It is awful how people are feeling. And it's because, things were really hard during COVID, but people getting clapped to work. People are now going on Twitter and seeing the Twitterati saying how awful doctors and nurses and ambulance people are, and it's their fault what's going on in the NHS. The mood of the workforce is awful. People are leaving. It's hard to recruit to. The NHS is nothing except its workforce. The NHS is its workforce, and any patient system, any patient safety things have to, underneath anything, any initiative, it's about people, people, people. So I've got a number of roles. Clinically, I'm an A&E consultant. I'm work at the medical school and head of undergraduate A&E. I also do a number of things outside of medicine. So I'm the Brighton Marathon medical director and organise the mass events there. And actually, the safety aspects of what I do there are all taken from what we've done in the hospital. And I'm also work for Brighton Hove Football Club as their crowd doctor. The thing I enjoy the most is being a crowd doctor, because I basically get paid to watch football with my kids and occasionally look after a member of the crowd who suddenly gets unwell. But again, into that, I've brought in a lot of the stuff I've done from safety. And there's a video I'd like to share with you where we've had a cardiac arrest which is on CCTV, and the person who survived is very happy for us to use it, which use a lot of the patient safety stuff where he collapses, he basically has a cardiac arrest, and there's some cognitive biases, there's groupthink where he doesn't get CPR straight away from the stewards, but the St. John come in and start the CPR, and then there's great human factors about how we call for help and organising the team, and he gets a return spontaneous circulation and he chats to us. Before I went into medicine, I didn't want to be a doctor. There's two things I wanted to do. One was be a footballer. I was really, really, really enthusiastic, but rubbish. And the other thing is, before medicine, I tried a couple of stints as a stand-up comic. I failed. I wasn't good enough, and so therefore I went into medicine. And one thing I have done, which might surprise people, is when I was a registrar, I wrote a book about what it's like working in A&E, but I wrote it under a pseudonym because at the time I didn't want to get sacked. It's called In Stitches, The Highs and Lows of Life as an A&E Doctor by Dr. Nick Edwards.